Welcome, everyone. Today I'm going to start a new series. It's going to be an internal medicine board review type question. So multiple choice questions in nephrology. The questions are also appropriate for certification, recertification of internal medicine, family medicine. They may also be appropriate for medical students and even for nephrologists. So there is something for everyone. I noticed that there's not much on YouTube when it comes to board review questions. Sometimes the quality is not very good. So I'm hoping to provide something helpful. I'm Dr. Mohammed Tinawi. I'm a nephrologist in Northwest Indiana. You can find more about my background in the description below. I'm also going to provide some references and other YouTubes related to the content. So let's get started. Question 1. We have a 42-year-old man presenting to his primary care physician office for evaluation of blood pressure. The patient has no cardiac risk factors. His average blood pressure readings taken at home at different times during the past month is 142/91. His blood pressure was measured 3 times in the office, 1 minute apart, and the measurement was done with an automated device without an observer, like it was done many times in the SPRINT study. And the average in the office was much lower, 121/79. What is the next step in the management? Start amlodipine 5 milligrams daily and see the patient back in 1 month. Implement non-pharmacological therapy. Or C, no action now, see the patient in the office in 1 week. D, proceed with ambulatory blood pressure monitoring, ABIM. Now here you are welcome to pause the video, read the question again, because I'm going to give the answer right away on the next screen. So pause. Answer is D, proceed with ambulatory blood pressure monitoring. I am going to explain in a little bit why. Starting amlodipine is too premature. Non-pharmacological therapy is a good idea, but you need to know if also you need medical treatment. No action now is inadequate because the patient can truly have high blood pressure. Let's review the definition of high blood pressure. This is based on the American Heart Association, American College of Cardiology 2017 report. Normal blood pressure now is defined as systolic below 120 and diastolic below 80. Now, elevated blood pressure is systolic between 120 and 129. The diastolic has to still be below 80. Now, if the diastolic is above 80, now we have stage 1 hypertension. So stage 1 hypertension is systolic 130 to 139 and diastolic 80 to 89. Stage 2 hypertension is a systolic equal to or over 140 or a diastolic equal to or over 90. So the patient in the question, based on his readings at home, he has elevated blood pressure, while the office readings show stage 2 hypertension. So we have a big difference. Now, here the patient is using his own home monitor. We really don't know what kind of monitor he's using. We don't know if it's an arm one, if it's a wrist one. We don't know if it's been calibrated. So we really don't have any idea about what's going on. Monitoring via ambulatory blood pressure monitoring, if you can get it covered by insurance, is very appropriate because we have 4 possibilities. Any person can be normotensive, meaning no high blood pressure, in the office setting and at home. So that's great. Now, some people are hypertensive in both settings, healthcare setting, office, and also home. Whether you're checking it at home or whether you're doing ambulatory blood pressure monitoring, the person is still hypertensive. Now here, the situation like in this question may represent masked hypertension. Masked hypertension meaning the person is hypertensive at home, but not in the office. In the office you have either elevated blood pressure or even normal blood pressure. And white coat hypertension is when you have hypertension only in the office while it's normal at home. Now, some people call white coat effect when blood pressure is higher in the office. So you still have hypertension, but it's a lot higher in the office setting. So if you can confirm any of these possibilities via ambulatory blood pressure monitoring, this is definitely the way to go. Question 2. A 40-year-old African-American man presents with blood pressure 131/82. The patient has had multiple blood pressure readings at home and in the office confirming a diagnosis of stage 1 hypertension. His only medication is metformin for type 2 diabetes mellitus. Total cholesterol is 230, HDL 30, LDL is 163. He's not on a statin or aspirin. He is a current smoker with 20-pack year history. What is the next step in the management of his stage 1 hypertension? A. Start lisinopril and schedule a 1-month follow-up appointment. B. Echocardiogram. C. Calculate his 10-year risk, cardiovascular risk, using the ASCVD calculator online. D. Start non-pharmacological therapy for hypertension and reevaluate in 3 months. Here you can pause, read the question. The answer will be on the next slide. The correct answer is calculate his 10-year cardiovascular risk using the ASCVD calculator. So for any patient with stage 1 hypertension, this is what we have to do. Non-pharmacological therapy is appropriate for any patient with elevated blood pressure, stage 1 hypertension, or stage 2 hypertension. But the calculation of the cardiovascular risk will enable us to determine whether drug therapy is needed. Putting the patient on lisinopril may or may not be a good idea. We really need to have an idea about his 10-year cardiovascular risk. An echocardiogram is really not necessary based on the information provided. Now, this is what the risk calculator looks like. I will provide the link in the description. And here I plugged in the information from the patient we just talked about. So age 40, male, African American, systolic and diastolic blood pressure, cholesterol information. He's diabetic. He's a current smoker. He's not on antihypertensive therapy. He's not on a statin, and he's not on aspirin. So this gives us a current 10-year cardiovascular risk of 12.4%. This is high because the optimal risk is only 2.3%. So this is well over 10%. Note that the lifetime risk is 69%. So this patient needs aggressive treatment to reduce the risk. So this is not only non-pharmacological therapy, but we have to treat his hyperlipidemia, we have to treat his hypertension, we have to control his blood pressure tightly, and last but not least, he has to quit smoking. This is based on the 2017 American College of Cardiology, American Heart Association guidelines for stage 1 hypertension, systolic 130 to 139, or diastolic 80 to 89. We have to calculate the cardiovascular 10-year risk. So if that number is less than 10%, then by all means do non-pharmacological therapy and then reevaluate blood pressure within 3 to 6 months. On the other hand, as in this patient, the atherosclerotic cardiovascular risk is over 10%, then we have to do both non-pharmacological treatment and antihypertensive drug therapy, and then we repeat blood pressure evaluation in 1 month. This patient is diabetic, so many people would start an ACE inhibitor or an angiotensin receptor blocker. It'd be very worthwhile to check a urine for albumin and creatinine to see if he has albuminuria. Other good choices include a diuretic, a calcium channel blocker, and like I said, an ACE or an ARB. All those are good choices. Question 3. A 45-year-old white man presents with blood pressure 151/92 millimeters of mercury. The patient has had multiple blood pressure readings at home and in the office confirming a diagnosis of stage 2 hypertension. His only medication is atorvastatin. Current 10-year ASCVD risk is 3%. What is the next step in the management of his stage 2 hypertension? A. Start losartan 25 milligrams daily and schedule a 1-month follow-up appointment. B. Start lisinopril 10 milligrams daily and amlodipine 5 milligrams daily and see back in 1 month. C. Reevaluate in 1 month. D. Start non-pharmacological therapy for hypertension and reevaluate in 3 months. So you can pause here to read the question, and the answer is B. Start lisinopril 10 milligrams daily and amlodipine 5 milligrams daily and see back in 1 month. Now, starting losartan 25 milligrams daily is unlikely to control this person's high blood pressure. So although this patient has a low cardiovascular risk, only 3% over the next 10 years, he has stage 2 hypertension. So when we have stage 2 hypertension, we have to treat with non-pharmacological therapy and pharmacological therapy right away. Now, since blood pressure is over 140/90, then we have to start 2 agents. These are the recent recommendations. I think it's a little bit controversial because many patients probably can be controlled with 1 agent, but according to the guidelines, start 2 agents, medium doses of 2 agents. And as you know, ACE inhibitors and calcium channel blockers work well together. And in this question, I didn't want to make it difficult, so I put losartan 25 milligrams because this is really unlikely to control blood pressure in the 150s over 90. So that kind of makes it obvious that choice B is better. But you can have a test question saying lisinopril 10 for A, and B would be lisinopril and amlodipine. So the right answer, at least for test purposes, is to start a combination of 2 antihypertensive medications. Reevaluating in 1 month with no further action is inappropriate because this patient requires treatment. His stage 2 hypertension is confirmed. Starting non-pharmacological therapy is needed, but in and of itself is not enough. You need medical therapy. To summarize, based on the 2017 American College of Physicians, American Heart Association guidelines for stage 2 hypertension, meaning systolic over 140, diastolic over 90, we have to treat with non-pharmacological therapy and antihypertensive medications. We usually use 2 agents of different classes, not of the same class, and then we repeat blood pressure evaluation in 1 month. Question number 4. A 48-year-old African-American man presents with blood pressure 118 over 77 millimeters of mercury. He is on metformin for type 2 diabetes, 1,000 milligrams twice a day, lisinopril 40 milligrams daily for high blood pressure, and atorvastatin 40 milligrams daily for hyperlipidemia. His urine albumin-creatinine ratio in the morning is 400 milligrams of albumin per gram creatinine. Obviously, this is very high. Laboratory values are significant for a creatinine of 1 milligram per deciliter and a potassium of 5.1 milliequivalent per liter. What is the next step in his management? A. Add irbesartan 300 milligrams daily. B. Increase lisinopril to 80 milligrams daily. C. Add spironolactone 50 milligrams daily. Or D. Start dapagliflozin 10 milligrams daily. You can pause here if you would like to read the question again, and the answer is D. Start dapagliflozin 10 milligrams daily. Now, adding an irbesartan to lisinopril, as in option A, is definitely a wrong answer. We know that this has no value because it will increase the incidence of acute kidney injury and hyperkalemia. The patient potassium is already at the upper range of normal 5.1. Increasing lisinopril to 80 milligrams is unlikely to result in any significant reduction in his albuminuria. So at 40, probably you got whatever you can get from lisinopril. Adding spironolactone 50 milligrams daily may cause further hyperkalemia. Then you'll have to use a potassium binder. There are small studies showing further reduction in proteinuria with spironolactone. If I'm going to start something, probably it would be 25 milligrams spironolactone. I have to follow potassium really closely. I may have to start a potassium binder like Potassium or sodium zirconium cyclosilicate. So definitely the best option is D. Start dapagliflozin, which is an SGLT2 inhibitor, 10, not 5, 10 milligrams daily. Here's the evidence of what I just said. All three trials were published in the New England Journal of Medicine. The first one is the VA Nephron D trial that showed combining an ACE inhibitor with an angiotensin receptor blocker is not beneficial due to increased incidence of acute kidney injury and hyperkalemia. The second is the DAPA-CKD trial with dapagliflozin in patients with chronic kidney disease, showing that adding an SGLT2 inhibitor, dapagliflozin, really resulted in slowing the progression of chronic kidney disease and death. And that was published in 2020. And most recently, we had very good data with empagliflozin in the EMPA-KIDNEY trial, published in 2023, showing also retardation towards end-stage kidney disease with empagliflozin. And I'm going to provide a link to all three studies in the description. Question 5. A 45-year-old white man presents with blood pressure 161 over 100 millimeters of mercury. Stage 2 hypertension was confirmed by multiple blood pressure readings at home and in the office. His only medication upon presentation is rosuvastatin for dyslipidemia. Current 10-year CVD risk is 5%. Upon presentation, his creatinine was normal, 0.8, sodium 142, and potassium is also normal, 3.9. The patient is started on two medications, as we've seen before, lisinopril 20 milligrams daily and hydrochlorothiazide 25 milligrams daily. 1 month later, at the follow-up, his blood pressure was down to 142 over 93. Creatinine was up to 1.1, sodium was 138, and his potassium was down to 2.7. What is the next step in his management? A. Discontinue both lisinopril and hydrochlorothiazide and start the patient on amlodipine 10 mg daily with potassium chloride. B. Add spironolactone 25 mg daily to current regimen. C. Check plasma aldosterone plasma renin activity ratio. D. Check CT scan of the abdomen and pelvis with and without intravenous contrast. You may want to pause the slide if you want to read the question again. And the answer is C. Check plasma aldosterone plasma renin activity. Now, option A is not good. It doesn't really solve the problem. You are adding one medication, amlodipine. It's unlikely to control his blood pressure if we have primary aldosteronism. Replacing potassium chloride is good, but again, you're not solving the problem. Adding spironolactone may help with the hyperkalemia, even with the blood pressure, but you're not making the diagnosis. Moreover, it will really make the screening impossible. You cannot add spironolactone if you are screening someone for primary aldosteronism. Doing CT scan of the abdomen and pelvis is too early. As a general rule, with any endocrinological problem, you have to prove that the condition exists chemically before you do imaging. So on this question or any endocrine question, first prove that the condition exists chemically and then follow up with imaging. Why? Because you might find an adrenal mass and it's an incidental mass. So that doesn't mean anything. You have to prove first that there is excess aldosterone production. Now, when do we screen for secondary hypertension? Most people, 90–95%, have primary hypertension. Now, when we have a secondary cause, it is important, and we screen for secondary causes if we have early onset of hypertension, age below 30, or if diastolic hypertension starts at age over 65, equal or over 65, if we have spontaneous hypokalemia upon presentation, or excessive hypokalemia when the patient is placed on a diuretic. In the question, the potassium was 3.9. You started hydrochlorothiazide 25 milligrams, so you would expect potassium to go down maybe by half a point. Okay, maybe it will go down to 3.4, but it went all the way down to 2.7. This is an exaggerated response to a diuretic, and that should make you suspicious of primary aldosteronism. We also screen for secondary causes if we have malignant hypertension. Okay, so you have severe hypertension with papilledema, proteinuria, or if we have significant worsening of previously controlled hypertension. Drug-resistant hypertension, and the definition I use is a patient is on full doses of 3 different antihypertensive medications from 3 different classes, including a diuretic. If blood pressure is still not controlled, then you've got a drug-resistant hypertension. Or if you have significant target organ damage, so you have hypertensive retinopathy, you have congestive heart failure, you have chronic kidney disease, so you have significant target organ damage relative to the degree of hypertension. So blood pressure is only 132/82, but you have significant significant hypertensive retinopathy that may make you want to screen for secondary causes of hypertension. Now, when we screen for secondary cause of hypertension, we're not going to screen for everything. They are common causes. Alcohol or drug-induced are very common, especially in the emergency room setting. I cannot remember how many times I've had a patient with severe hypertension. You do urine drug screen and it's cocaine. So please, before you screen someone for pheochromocytoma, and you should, okay, in severe hypertension, do a urine drug screen, okay? So alcohol or drug-induced, very common cause of secondary hypertension. Chronic kidney disease, and this is a chicken or egg problem. Did the hypertension cause chronic kidney disease, or did the chronic kidney disease cause hypertension? Renovascular hypertension, as in renal artery stenosis, primary aldosteronism, and obstructive sleep apnea. Uncommon causes, although very serious if missed: pheochromocytoma, Cushing's syndrome, both hypo and hyperthyroidism, primary hyperparathyroidism, congenital adrenal hyperplasia, and acromegaly. Now, to end this question, when do we screen for primary aldosteronism? Again, resistant hypertension, like we said, 3 full doses of medications from different classes, including a diuretic. If we have spontaneous hypokalemia, I cannot tell you how many times I've seen patients with hypertension and chronic hypokalemia for 10 years, and no one screened them for primary aldosteronism. If you have hypokalemia, ask yourself why. Don't just throw potassium at it. So spontaneous hypokalemia, severe diuretic-induced hypokalemia, like I said, you give hydrochlorothiazide, you expect potassium maybe to go down by half a point. If it went by 2 milliequivalents per liter, that's too much. On the other hand, if you have a potassium of 4 and you start someone on furosemide 80 milligrams 3 times a day, plus metolazone 10 milligrams a day, and then potassium goes down by 2 milliequivalents per liter, that's not surprising. That's not an exaggerated response. If you have incidental adrenal mass, that screening for primary aldosteronism, amongst other things, is needed. And on the screen, you see an example of an aldosterone-producing adenoma. If you have a cerebrovascular accident below age 40, and if you have family history of early onset hypertension. Question 6. A 55-year-old man is seen for evaluation of 90% proximal left renal artery stenosis, incidentally found on a CT angiogram of the abdomen. He presents with a blood pressure of 151/95 millimeters of mercury. The patient therefore has stage 2 hypertension, and that was confirmed by multiple blood pressure readings at home and in the office. The patient was on no medications at the time of the presentation. Creatinine 1.2 mg per deciliter, sodium 142, and potassium is 3.5 milliequivalents per liter. What is the next step in his management? A. Refer for endovascular intervention, mainly balloon angioplasty and stenting. B. Start amlodipine 5 mg daily and repeat CT angiogram in 6 months. C. Proceed with renal arteriogram. D. Start candesartan 60 mg daily, amlodipine 5 mg daily, and atorvastatin 40 mg daily with follow-up in 1 month, including repeat labs. You can pause here, and the answer is on the next slide. The correct answer is D. Start candesartan, amlodipine, and atorvastatin with follow-up in 1 month. Now, referring for endovascular intervention is inappropriate. The renal artery stenosis was found incidentally. The patient did not have resistant hypertension. He wasn't even on any medications. We haven't tried anything. He was not in congestive heart failure. We did not have a deteriorating renal function. Answer B, start amlodipine 5 mg daily is inadequate. This is unlikely to control his blood pressure and will not address the atherosclerosis in the renal artery. There's no big advantage from repeating the CT angiogram in 6 months. Proceeding with renal arteriogram is also the wrong answer because nowadays with 3D CT scanning we have enough information and we do not need confirmation with a renal arteriogram. Answer D may seem surprising. Why would you start an ACE inhibitor or an angiotensin receptor blocker in a patient with renal artery stenosis? Wouldn't that sometimes cause acute kidney injury? The answer is yes, but this is actually what was done in the big clinical trial, the CORAL study, which I am going to discuss in detail. So they did the angiotensin receptor blocker plus the amlodipine plus the atorvastatin with very good results. So let's look further into that. This is the study that we all should be familiar with, the CORAL study, the biggest study in renal artery stenosis, published in 2014 in the New England Journal of Medicine. I will provide the link in the description. When we talk about lesions associated with renovascular hypertension, we have two possibilities. Fibromuscular disease, which you find particularly in young women. This is the string of beads appearance. In that case, you go directly to intervention. So you do angioplasty and you may cure the hypertension. Now, this is not the case in our patient. Our patient has the more common atherosclerotic renal artery stenosis. This is you find in 60, maybe close to 80% of people. It's proximal, it's near the ostium, and it's part of a spectrum of atherosclerosis. Now let's look at the CORAL study in some detail. It was the cardiovascular outcome in renal atherosclerotic lesion CORAL study. It is a very large study, close to 1,000 patient, multi-center, randomized, was funded by the NIH. It compared the outcome of optimal medical therapy and optimal medical therapy plus stenting, revascularization versus medical therapy alone. And the end result was a composite endpoint of both cardiovascular and renal events. So the outcome of the study was renal artery stenting did not confer a significant benefit with respect to prevention of clinical events when added to comprehensive medical therapy in patients with atherosclerotic, again, atherosclerotic renal artery stenosis and hypertension or chronic kidney disease. Now, when you look at the data, when you dissect the data, there's still no difference in any subgroup. During the follow-up, which was for about 43 months, there was a consistent, although modest, difference in systolic blood pressure favoring the intervention, the stenting, minus 2.3 millimeters of mercury only. Now, to include a patient in the CORAL study, the patient needed at least 60% stenosis. And when they did a subgroup analysis in patients with over or with at least 80% stenosis, there was still no benefit. Most patients were diagnosed via angiography. About 25% were diagnosed with duplex ultrasound. Medical therapy was with candesartan plus or minus hydrochlorothiazide and amlodipine atorvastatin. Blood pressure target was 130/80 in patients with diabetes mellitus or chronic kidney disease. For all others was less than 140/90. There was not much crossover or discontinuation. In conclusion, patients with incidentally found renal artery stenosis do not require intervention. You only do intervention or consider intervention if you have a fast deteriorating renal function, or if you have a resistant hypertension, the patient is on 3, 4, 5 medicines and blood pressure is still uncontrolled. Another instance is when you have acute pulmonary edema. So someone with renal artery stenosis coming to the hospital once, twice, 3 times with pulmonary edema, then an intervention is required. Other than that, the correct answer would always be medical treatment first. Question 7. A 70-year-old man with a known history of coronary disease presents with severe anterior chest pain described as tearing. A STAT-CT angiogram reveals type A aortic dissection. His medications include aspirin, amlodipine, metoprolol tartrate, and atorvastatin. Blood pressure was 174/94 upon presentation. The cardiothoracic surgeon was immediately notified. How should his blood pressure be managed? A. Change metoprolol tartrate to metoprolol succinate at 200 milligrams PO daily. B. Start sodium nitroprusside intravenously to rapidly lower systolic blood pressure to below 120 millimeters of mercury. C. Start ismolol intravenously to rapidly lower systolic blood pressure to below 120 millimeters of mercury. Or D. Start labetalol IV to gradually lower systolic blood pressure to equal or below 140 millimeters of mercury over the next 6 hours. You can pause here and read the question again if you wish, and the answer is on the next slide. The correct answer is C. Start ismolol intravenously to rapidly lower systolic blood pressure to equal or below 120 millimeters of mercury. This represents a true hypertensive emergency. We should lower blood pressure very rapidly to equal or below 120 millimeters of mercury systolic. This should be achieved first with a beta blocker. We can use esmolol or labetalol intravenously. Now, if that does not achieve target, you can add a vasodilator such as nicardipine intravenously or sodium nitroprusside. But to decrease, to lower the wall stress of the aorta, you must start with an intravenous beta blocker. So answer A is very inappropriate. You cannot treat this with oral beta blockers. Answer B, sodium nitroprusside to lower blood pressure to equal or below 120, is incorrect because you have to start with a beta blocker. You can add sodium nitroprusside later to the beta blocker if that's not enough. Answer D is incorrect because lowering blood pressure gradually over 6 hours is inappropriate. So that leaves us with answer C, start esmolol intravenously to rapidly lower systolic blood pressure to equal or less than 120 millimeters of mercury. Question 8. A 28-year-old woman who's gravida 1, para 0, in her 36th week of gestation presents to the emergency department with lower extremities edema, proteinuria 500 milligrams of albumin per gram creatinine, and a blood pressure of 160/92. An obstetric consultation was immediately obtained. The patient was given labetalol 300 milligrams orally and nifedipine 60 milligrams orally in the emergency department. 1 hour later, Her blood pressure is still elevated, 162/94. How should her blood pressure be managed as she's being prepared for delivery? A. Continue labetalol and nifedipine and add hydralazine orally. B. Continue labetalol and nifedipine and add methyl-dopa orally. C. Discontinue oral medications and start intravenous sodium nitroprusside drip and intravenous enalapril. Or D. Start nicardipine drip. The answer will be on the next slide. The correct answer is D. Start nicardipine drip. Answer A is wrong because adding hydralazine orally is not going to solve this hypertensive emergency. The patient's blood pressure had to be lowered. Otherwise, you can risk changing preeclampsia to eclampsia and seizures. B is also incorrect. Adding methyl-dopa will not achieve the quick blood pressure lowering that is desirable in this case. C is also incorrect. Sodium nitroprusside intravenously and enalapril intravenously are good ideas for someone who's not pregnant. Intravenous sodium nitroprusside, while very effective, can cause cyanide toxicity and even death. So obviously we don't want to do that in pregnancy. Intravenous enalapril, as you know, enalapril is an ACE inhibitor, and these medications are contraindicated in pregnancy. Someone might say, well, she's being prepared for delivery. One dose isn't going to do anything. Well, we have black box warning, and you have alternatives, so why go there? The correct answer is D. Start nicardipine drip. So nicardipine is a non-dihydropyridine calcium channel blocker. It's very effective in all kind of antihypertensive emergencies, and we can use it in this situation to lower blood pressure, and you can easily titrate the nicardipine drip to achieve your goals. I can say that you probably can use nicardipine for pretty much any hypertensive emergency, except like we said in the previous question, in question number 7, when you have aortic dissection, you want to use an intravenous beta blocker first. But for general purposes, intravenous nicardipine drip is a good idea. Now, alternatively, you can use labetalol drip. So you can use labetalol drip IV. Okay, so you give your boluses first and then you start drip, not orally for this kind of emergency. Now, number 3, let's say that you don't have drips, you're in a situation where you have to do something, you can use intravenous hydralazine. However, you don't have the same control. The results are variable and not very predictable. So my first option will be nicardipine drip and labetalol drips. Question 9. A 42-year-old woman presents to the office for blood pressure evaluation. The average of 3 blood pressure readings at the office is 125/78 millimeters of mercury. Her home blood pressure average readings over the past month is 123/79 millimeters of mercury. What is the appropriate next step? A. Continue home blood pressure monitoring and re-evaluate in 6 months. B. A trial of lifestyle modifications, also known as non-pharmacological therapy, and re-evaluate in 6 months. C. Start hydrochlorothiazide 12.5 milligrams daily in addition to a low sodium diet. Or D. Arrange for ambulatory blood pressure monitoring. You can pause here if you want to read the question again, and the answer is on the next slide. This patient has elevated blood pressure, and option A, continue home blood pressure monitoring with re-evaluation in 6 months, is inappropriate because you're really not doing much. B is the correct answer. According to the new guidelines by the American Heart Association, American College of Physicians in 2017, in those patients with elevated blood pressure, we should try lifestyle modifications or non-pharmacological therapy for 6 months, and then we reevaluate. If things aren't working, maybe a drug therapy for hypertension can be considered. Starting hydrochlorothiazide or any antihypertensive medication is too premature, especially the question really didn't give you any particular risk factors or end organ damage. Now, something I have to note here, since I did not give you in the question any end organ damage or risk factors or other medications, don't assume that it exists. The question writers are not trying to trick you. So if something is not in the stem, then it doesn't exist. Okay. D, arranged for ambulatory blood pressure monitoring. This has little value. Really, the blood pressure was confirmed by both home and office readings. Now, on this slide, we are going to discuss the non-pharmacological therapy. So everything on this slide is what works. Everything else doesn't. So weight loss is very appropriate, and the patient initially can lose weight and drop blood pressure by 1 millimeter of mercury for each kilogram. A healthy heart diet or a heart healthy diet, such as the dietary approaches to stop hypertension, is very helpful, can drop blood pressure by up to 10 points. So this is not just low sodium, but it's high potassium diet. This is a plant-based diet, high in fruits, in vegetables. There's also low-fat dairy products. There's little meat. Low sodium and high potassium diet, especially from fruit and vegetables, not supplements. Exercise is helpful even if there's no need for weight loss. Limiting alcohol intake to less than 2 drinks, which is equivalent. Each drink is like one beer. About a 12-ounce beer is considered 1 drink. So less than 2 drinks for men and less than 1 drink for women. So the maximum is 1 drink per day for women and 2 drinks per day for men. People who don't drink, that's even better. And tobacco cessation, this is to reduce cardiovascular risk. Now, if patients ask you about anything else, unfortunately, it doesn't work. There's no consistent evidence that, say, yoga would drop blood pressure or meditation would drop blood pressure or eating garlic or onions, this or that. All these claims are unsubstantiated. If the patient want to do meditation while eating garlic, that's fine, but it's not going to drop their blood pressure. Question 10. A 57-year-old man with a known history of heart failure with reduced ejection fraction presented to the office for a routine visit. His medications include sacubitril valsartan 49-51 milligrams a day. This is Entresto. Carvedilol 25 milligrams BID. Dapagliflozin, which is Farxiga, 10 milligrams daily. Chlorthalidone 25 milligrams daily. And atorvastatin 40 milligrams daily. He's been stable clinically. Laboratory evaluation reveals BUN 31, creatinine 1.5, both in milligram per deciliter, sodium 134, and potassium was elevated at 5.6, both in milliequivalents per liter. What is the appropriate next step in management? A. Discontinue sacubitril valsartan and start a low potassium diet. B. Discontinue chlorthalidone and start furosemide 80 milligrams PO twice daily. C. Continue current treatment and start a potassium binder and a low potassium diet. Or D. Continue current treatment, start low potassium diet, and recheck potassium in 1 week. You can pause to read the question, and the answer will be on the next screen. The correct answer is C. Continue current treatment and start a potassium binder and a low potassium diet. Now, this is an example of a stable patient. We have here a compelling indication to continue sacubitril valsartan. So this patient has stage 3 chronic kidney disease. We don't know why, but that doesn't matter. What matters is he must stay on the sacubitril valsartan because it will reduce the morbidity and mortality of his heart failure with reduced ejection fraction. Now, we have 2 new potassium binders. One is Proteinuria or Veltassa, and the other one is Lokelma or sodium zirconium cyclosilicate. Both are appropriate for long-term chronic use. So for a patient like this, you continue the same medication. You don't reduce the dose because the patient is stable. You continue current treatment and start the patient on a potassium binder in addition to a low potassium diet. If you need help, you can ask for a renal consultation. So the correct answer then is option C. Option A is inappropriate because you're discontinuing a life-saving treatment, even though you're doing a low potassium diet. So that's a bad idea. Option B, discontinuation of chlorthalidone and starting furosemide, yes, that will give you a lower potassium because furosemide is going to give you more diuresis, but the patient is stable. He doesn't need more diuresis. This is going to drive his potassium higher. This will drive his creatinine higher, can lead to acute kidney injury and dehydration. So that's also inappropriate. Option D, continue current treatment and start low potassium diet and recheck in 1 week. This is also inappropriate because really you have not done much. Just a low potassium diet is not likely to be consistently of benefit in this patient. The potassium is significantly high. If the potassium was, say, 5.3, you probably can do that, but this is a potassium above 5.5, so we have to take more action to guarantee continuation of the sacubitril valsartan. Question 11. A 57-year-old man presents to the office for evaluation of uncontrolled hypertension. Average blood pressure readings based on ambulatory blood pressure monitoring is 153 over 94 millimeters of mercury. He adheres to a low sodium, high potassium diet. He does not smoke, use illicit drugs, or drink alcohol. He has a strong family history of hypertension. His medication regimen includes amlodipine 10 milligrams daily, lisinopril 40 milligrams daily, and hydralazine 100 milligrams 3 times daily. What should be done next? A. Obtain a 24-hour urine collection for sodium and creatinine to confirm his adherence to a low sodium diet. B. Start hydrochlorothiazide 25 milligrams daily. C. Obtain urine drug screen. Or D. Add clonidine 0.1 milligrams TID. You can pause here to read the question. The answer will be on the next slide. The correct answer is start hydrochlorothiazide 25 milligrams daily, or option B. I said before that the definition of resistant hypertension is a patient on 3 different antihypertensive medications at maximum doses, but those medications should include a diuretic. So this patient has resistant blood pressure, but he's not on a diuretic, so we cannot technically call it resistant hypertension. We have to add a diuretic. And really in the office I see that a lot. Patients come in and they're not on a diuretic. You add a diuretic like hydrochlorothiazide or chlorthalidone. You can also use indapamide, and then blood pressure really drops nicely. Now, when we're starting blood pressure treatment, we have to consider the 4 classes of antihypertensive medications. So we have the thiazide diuretics. Okay, usually we don't need loop diuretics unless someone has advanced chronic kidney disease. So we have hydrochlorothiazide, chlorthalidone, indapamide. We have calcium channel blockers, dihydropyridine. The non-dihydropyridine, verapamil, and diltiazem we don't use unless there is another indication. Then we have the ACE inhibitors and the angiotensin receptor blockers. And then we have the beta blockers. Beta blockers also, we don't start with those unless there is an indication like atrial fibrillation, myocardial infarction in the history, etc. Now, other medications like hydralazine, minoxidil, clonidine, they should not be used first. So option D, adding clonidine, is not correct. Even for this patient, there was no clear reason to start hydralazine this early. If hydrochlorothiazide fails and there are no secondary causes, then hydralazine would be reasonable. Option C, obtain urine drug screen. There's nothing in the history to suggest that the patient is on drugs, and I said that he doesn't smoke, drink alcohol, or use drugs, and I didn't give you anything to dispute this statement, so it's not the best answer. It's not a bad answer, but not the best answer. Option A, obtain 24-hour urine collection for sodium and creatinine to confirm his adherence to low sodium diet, like to verify that sodium in the urine is below, say, 100 milliequivalents per day. Again, he's been adhering to the diet. He's saying that, and I didn't give any indication that this is not the case. I've done that on occasions. If you want to do it, don't tell the patient anything. Collect the urine for creatinine, protein, and sodium, and then you can get a clear picture. Actually, for many patients, you will be unpleasantly surprised regarding their compliance. To summarize, if you have a patient with high blood pressure, not controlled, with multiple medications, add a diuretic. This is the last question, question 12. A 51-year-old woman presents to the office for evaluation of uncontrolled hypertension. Average blood pressure readings based on ambulatory blood pressure monitoring is 139/84. She's on metformin 1,000 milligrams twice daily for type 2 diabetes mellitus. She has a strong family history of hypertension. Urine albumin creatinine ratio is very high, 441. Normal should be less than 30. Hemoglobin A1C is 6.8%. What should be done next? A. Obtain a 24-hour urine collection for protein and creatinine to confirm proteinuria. B. Start hydrochlorothiazide 25 milligrams daily. C. Start lisinopril 10 milligrams daily. D. Add dapagliflozin or Farxiga 10 milligrams daily. You can read the question, pause if you would like, and the answer is on the next slide. The correct answer is start lisinopril 10 milligrams daily. So for patients with diabetes mellitus and proteinuria and hypertension, you start an ACE or an ARB. That's it. End of the question. This is a compelling indication. So the correct option is C. D is not a bad option after you start the patient on an ACE or an ARB and you maximize the dose. If you're still not at target, then you can add an SGLT2 inhibitor such as dapagliflozin. So that's too premature. Starting hydrochlorothiazide 25 milligrams daily may get you to blood pressure target of below 130/80, but it will not address the albuminuria. Obtaining a 24-hour urine collection for protein and creatinine to confirm the proteinuria is really not necessary for most patients. A random urine for protein and creatinine or albumin and creatinine and then calculating the ratio is good for most instances. So that will not add much to our information. I hope that you have enjoyed the previous cases. Please send me your comments, and I really hope that I'll be able to do other YouTube videos regarding other sections in nephrology. See you soon.